Good afternoon. This is Dr. Grabowski once again for our weekly webinar on introducing you into the SpectraCell testing procedures. And as you know, this month has been correlating the various testing with diabetes. Next month it'll be thyroid, and then we will do some other conditions in the future. Today my more or less object to you is to get you familiar with the CBC Comprehensive Metabolic Panel and how the micronutrient test correlates with this. And I'm going to show you how a micronutrient test may actually find some early deficiencies that may not show up in your CBC or your CMP. You know, all of us were trained on the CBC and CMP, and I think when we look at algorithms, we look at the top of the algorithm, and if the CBC or CMP is abnormal, then of course we branch down into various tests. I think it's very misleading because I think all of us can say that we've had numerous patients throughout the years where a person comes in, they're not feeling well, and we perform a CBC, CMP, and also a urinalysis, and everything comes out normal. And of course, a lot of doctors will say, oh, nothing's wrong with you, go home, it's probably just stress or something like that. And this is really the point that I want to emphasize today on how performing a micronutrient test may actually lead us down the road. For those of you that are just joining us for the first time this month or are not very familiar with SpectraCell, the micronutrient test, as you know, utilizes the lymphocyte, and this cell, once again, recycles about every 6 to 9 months, so it looks back 6 to 9 months of a person's health. And this is the main test that we try to correlate all the other tests with. And once again, the first webinar of this month, we actually went into in depth on how that is performed in the laboratory. We also mentioned last time, of course, how the patient history really affects individual, and of course these are some of the main objectives of what we look at when we're trying to determine why a person may feel the way they feel or may be deficient in a particular nutrient. And of course there are some other ones that come into play, but these are probably the more common ones that we look at. When we are looking at the exam, once again you will see that we have functional deficiencies and then we have borderline deficiencies. And as I've mentioned to all of you in the past, if you've had me for a consult or talk to the other consultants, that you want to treat the borderline deficiencies like the functional deficiencies because of the time frame that we look at for retesting, which is, once again, 6 months. And so I'm going to try to correlate these some of these particular deficiencies with the CBC today as well as the CMP. This is an example of 2 general findings that we look at. We look at how the antioxidants of an individual are handling the free radicals in that particular individual, and that would be noted by the Spectrox. And then the immunodex is a general marker for the immune system, but really is indicating the first 5 days of growth of the testing procedure. And this is very important to look at, and both of these are difficult to maintain because they are so dependent upon other nutrients. Now, once again, you saw a general front page summary of the deficiencies, and now once again this is showing you some of the borderlines as well as the functional deficiencies. And of course the functional deficiencies are noted with red squares. The borderline deficiencies are noted with the black squares, and of course if the person is normal for a particular nutrient, they're noted with a green square in the white area. And once again, I'm going to bring forward how some of these deficiencies come into play. For example, the B12 and the folate, I'll show you on the CBC how they may present and how you may have been looking at a CBC in the past and really narrowed it down to 1 or 2 nutrients when in essence it may include several nutrients. This is just a blow up once again of these particular B vitamins. And just to reiterate, if you weren't with us the first 3 weeks of this month, is whenever you see a person's B vitamins all around the borderline values or the deficient area, meaning the yellow end or the blue, that this person is highly under stress. It could be physical stress like exercise, for example, marathoners, triathletes, CrossFit people, or it could also be psychological stress where a person has a extremely stressful job. It could be a clinician, it could be a CPA around, of course, April 15th. It could be an attorney or something like that, but this is something I see quite often. And once again, these are the individuals that come and say they aren't feeling well and they want to be tested. And this is where I'm going to show you where the CBC really doesn't show us what we want to see. And if we just use the old testing, or the customary testing of the CBC and CMP, we're going to miss a lot of these deficiencies. Going to the next group, of course, we have amino acids and metabolites, and looking at choline and inositol. We look at glutamine, and glutamine is going to come up later today in the talk when we talked about the integrity of the white blood cell and something that's very important for the immune system. And this is something that I think a lot of people, when they talk about the immune system, they primarily jump on vitamin C and or zinc. More and more people now are starting to maybe consider vitamin D, which is highly associated with the immune system. But the point is that there are several nutrients that really affect our immune system, and we need to address all of them. This, of course, is a lower portion of the first page of the testing, and you can see here where vitamin A is in the borderline and vitamin D is borderline. And once again, I'm going to correlate how some of the things on the CBC and CMP may correlate with, once again, these two nutrients. Or if you did this test first, you would then see that it's an early sign of something going on biochemically, and yet it may not have displayed itself yet in the CBC. Of course, there's a portion of the micronutrient that deals with insulin resistance as well as fructose metabolism. We know that chromium has a part to play with the insulin receptors, and so usually when we see a chromium that's borderline or deficient, we will also see a glucose-insulin interaction. However, we will talk about serum glucose today and show you how serum glucose on a CMP, once again, would be affected by this particular nutrient. However, there are other nutrients that also have a role to play with the serum glucose. And if you're just, for example, throwing chromium at people and telling them to take that to correct a serum glucose level, you may be on track, but yet you may be missing other nutrients that are very, very important in the person's condition. Then, of course, this is an example of the antioxidants that we look at in correlation with the SpectraCell, and some of these, of course, also have immunological function, and so they will also affect the immunodex that I showed you earlier. This, once again, is just a summary of what I just showed you as far as the carbohydrate metabolism, the SpectraCell, the individual antioxidants, and the immunodex. Now, I want to point something out because a lot of clinicians ask me this. They'll say, well, Ron, how can the immunodex be normal if we have certain nutrients that have immunological function that are borderline or deficient? What that tells us is that the other nutrients that have immunological effect are really protecting this particular individual's lymphocytes, or that some of the nutrients that we sometimes associate with the immune system, for example, vitamin C, may not have as big impact on the lymphocyte as, say, glutamine, vitamin A, or vitamin D. The same thing is true with the SpectraCell. As you can see here, this person has two nutrients, vitamin E and alpha lipoic acid, that are borderline. You would think that that would pull the SpectraCell down a little further, but the reason why the SpectraCell is in pretty good status, even though it's just slightly in the yellow, is because the glutathione and cysteine here are so important. And usually when those two are high like this and in very good status, it has a significant impact on the SpectraCell. So the first thing we're going to talk about is when we talk about an individual's CBC, of course, we look at red blood cells, white blood cells, and hemoglobin, and so on. And one of the things that often comes up when people talk about abnormal hemoglobin is what nutrients are involved in. Of course, most people jump on iron. And once again, we'll come back to that. But this is just a summary of the nutrients, the micronutrient test that we talked about earlier. And once again, the SpectraCell that I mentioned. And now we're going to get to, of course, the CBC. So as I mentioned, when we talk about a decreased hemoglobin, is most people, most clinicians right away will go out there and look at iron and supplement people with iron. And I'm going to show you how that can very easily be not so much detrimental, but masking of the problem. Is there's several nutrients that actually come into play when we are looking at hemoglobin. And once again, so we have to look at these particular products. The Immunodex is, once again, showing you the relationship of the overall immune system, and does have a part to play with the CBC, and I'll show you how that, once again, comes into play. So here the person may have a normal Immunodex, and yet may have some underlying deficiencies that also are not necessarily showing up in the CBC as of yet. So when we talk about the CBC, of course, starting with red blood cells is if, and I'm just going to talk about the nutritional relationships now. There are various pathologies that could cause red blood cells to be decreased, but I'm just today relating it to nutritional factors. And as I mentioned, if someone is anemic and all you see on the CBC is that their red blood cell is low, the question is, how do you know what nutrient or nutrients to give them? Because if you see their red blood cell count is low and you say, well, I'm going to give you iron based on the MCV, or I'm going to give you folic acid or B12 based on the MCV, I'm going to show you how that could also be mistaken for a wrong diagnosis or wrong treatment. And all of us at one time in our career probably have supplemented people with certain nutrients before we had more specific testing like SpectraCell and did not correct it. You know, I hear this a lot from OBGYNs where they, of course, see a woman that's pregnant, they give them a prenatal that has iron in it, and throughout 9 months they never correct the anemia that the woman is suffering with. And so she's fatigued all the way through pregnancy. And once again, it's because they thought that it was iron and it actually could have been something else. So whenever you see a decreased red blood cell count in or on a CBC, you definitely want to look at these nutrients. So you can see B6 deficiency will do that, B12, of course, iron, folic acid. Vitamin E will give us more of a hemolytic type anemia because vitamin E deficiency affects, of course, the cell membranes. Of course, we could have a person that's overhydrated, which is very rare, but once again could occur. Essential fatty acid deficiency, once again, that could be where a person has poor cell membrane integrity. Then, of course, a vitamin K toxicity. So, once again, this happens more if a person is getting an injection with vitamin K. It doesn't happen very often if a person is taking oral intake of vitamin K. If you're trying to correct the vitamin K with a probiotic, in fact, like the K2 that you're trying to improve, it's very, very difficult to get into this toxic range. However, the thing I want to point out is when you are giving a fat-soluble nutrient in high amounts, say for vitamin D, since that's such a common nutrient today, you may actually cause deficiencies in other fat solubles. In this case, if you had a vitamin K toxicity, you actually could be pushing a person into vitamin D, A, and E deficiencies. Riboflavin, once again, could be deficient, which could affect the red blood cells, and of course then you could have a genetic abnormality with the glucose 6-phosphate dehydrogenase abnormality. Now, as I mentioned, when people talk about hemoglobin and it's low, right away they want to jump on iron. And the point is, if you had a hemoglobin that is low, and even if you did a iron profile, and the iron profile came back normal, but yet the hemoglobin was low, this is where you might want to suspect something like B6 deficiency. And you can see here that B6 is very important for this particular enzyme that is B6 dependent and is involved in the first step of the heme synthesis. So we know that heme has to be made first, and then it hooks onto globin, of course, and that's where we get the hemoglobin. So B6 deficiency can cause a low hemoglobin and, once again, present or look like an iron deficiency. Who might be more prone to this? B6 deficiency is common in gluten-free diet consumers. B6 deficiency is common in women that take oral contraceptives. People that consume a lot of diuretics in their diet, alcohol, caffeine. People that take prescription diuretics, such as hydrochlorothiazide, may be more prone to B6 deficiency. So once again, this may be an underlying cause of a low hemoglobin, and yet if you're throwing iron at these people, you're not going to correct this problem because you may mask it. You may see some improvement with the hemoglobin, but you're not really correcting the problem. The second step of heme synthesis is, once again, dependent upon this particular enzyme, which is zinc dependent. And so once again, this is why zinc deficiency can cause a low hemoglobin. And once again, when we have a low hemoglobin, we often see a microcytic type of anemia. So B6 deficiency can give us a microcytic anemia and hypochromic. Zinc deficiency can do the same. Iron deficiency can do the same. And so you can see here, by looking at a CBC, there is no way that you can say exactly what this person needs nutritionally just by the general CBC. So then you may say, well, what happens if the CBC is normal and the person complains about fatigue? So they could have a so-called borderline value of zinc or borderline value of B6 where it doesn't present yet as a low hemoglobin, but it may be a low normal hemoglobin or a low normal RBC count, which once again may suspect of something is going on. And it may be symptomatic to that person, but yet from an objective standpoint, it has not changed the CBC into the abnormality. And then, of course, the final step of heme synthesis involves the insertion of course, iron, and this makes heme. Then heme, of course, connects to the globin, and that's where we get the hemoglobin. So you can see there's three nutrients right away that we have to think about that are correlative with a low hemoglobin on a CBC. But once again, the literature shows this, and I've seen this in my practice, and you probably have also seen this in your practice, where a person doesn't display an abnormal CBC yet, but yet when we go into these other more specific testing procedures like the micronutrient test, we see these deficiencies. It's just like a person that has hypothyroidism, or I should say thyroid-like abnormal signs and symptoms, and their TSH is normal. It's normal within the typical range, but it may be symptomatic to them. So they may have like a 3 TSH, which we know is within the normal range of TSH, but yet at 3, these people are symptomatic. So we'd have to look at some other nutrients to see if that's involved. We also always have to consider protein deficiency with these particular individuals. And as you can see, of course, we need the protein for the globin portion of heme. These are a couple amino acids, the glycine and alanine, that are very important for that. You can see if a person has hydrochloric acid that's decreased, that once again could cause protein deficiency. So a person's on a PPI or they're on a histamine antagonist, something like that that's causing the individual to not be able to, once again, break down their protein, get in the amino acids to help make the globin. Person could have liver disease, which are affecting, of course, their globulins and their albumin, and once again could also be a factor for a low hemoglobin. Then, of course, we have intestinal inflammation where we're looking at, of course, malabsorption. Of course, the main nutrient or the main area that we'd be looking for protein uptake would be the small intestine. That there's a very small amount in the colon that occurs, but the small intestine is the main area of uptake for our amino acids. And as you know, we can absorb up to a tripeptide when it comes to proteins. Now, what about increased hemoglobin? This is something else that I think is very important. That, we always look at and case of hemoglobin, is a low hemoglobin to be detrimental, but does a high hemoglobin tell us? And these are, once again, this isn't encompassing all of the conditions that can cause an increased hemoglobin. But, for example, a person comes into the office that's dehydrated. Maybe they came from the track, or maybe they came from a heavy workout from the gym, and now they come into your office, they're not feeling good, and all of a sudden you send them out for a CBC and you get a high hemoglobin. You might think, oh my gosh, the person might have hemochromatosis or something like that, but you didn't ask the question, did you come from working out, did you drink enough water, anything like that. Are they smokers? Of course, as we know, we are going to damage our lungs, and as a result, when we do that, we're going to increase our requirement for oxygen carrying capacity, and hemoglobin is going to be increased, trying to compensate for the poor lung function, and that's where the COPD individual comes into play. That a chronic asthmatic person or bronchitis person could once again have an elevated hemoglobin. So instead of just thinking about hemoglobin as a decreased value, we have to also think of it as what's going on with an increased value. Hematocrit, of course, you can see a lot of times we think about a decreased hematocrit. And here's once again an example of increased hematocrit where it could be dehydration as well as just like a hemoglobin. But what we call secondary polycythemia, so people that are getting B12 injections on a regular basis, maybe once every week they're getting an injection because they feel so bad. Maybe another situation where a person is taking testosterone, and we know that testosterone can elevate our red blood cell count and as well as our hematocrit. And so this is something that needs to be monitored on a regular basis. Or a person is taking a lot of B complex that's high in B12 and can do that as well. So once again, we don't want to just think as a low level of the hematocrit, but also is what happens if it's increased. When we talk about decreased hematocrit, of course, a generalized malnutrition, something like, of course, protein, calorie malnutrition. But you can see that there are some nutrient deficiencies that come into play. B12, the folate, the B6, the vitamin C. So if you maybe know that this person has an abnormal MTHFR, and you know that they may not convert well from, say, folic acid to the methylfolate, this would be an example where the hematocrit may be low even though they are taking a product that should normalize the hematocrit. There's some studies out there showing that when people have decreased hematocrit and elevated MCV, that, of course, everybody usually jumps on B12 and folate, but yet they've shown that when vitamin C was administered to individuals that had those findings, that they actually corrected their MCV with vitamin C, and that's where it's because it's a synergistic nutrient with folate. As I mentioned on our previous slides with zinc deficiency and being involved with hemoglobin production, the second step is that folate's a good example where if we're consuming a large amount of folate, this could affect our zinc, and so once again could cause a different type of anemia because, as we know, folate, generally speaking, will give us a macrocytic or megaloblastic anemia, where zinc deficiency will give us a microcytic hypochromic anemia. And then, of course, hemolysis could also affect the hematocrit. And think of anything that decreases the integrity of the cell membrane. It could be elevation of free radicals. It could be deficiencies of things like essential fatty acids, vitamin E that we talked about, glutathione or cysteine levels that are abnormal, where the free radicals are overwhelming this cell membrane and damaging the cell membrane, so the red blood cell hemolyzes more rapidly. Now, as you know, we look at various indices when we're talking about the red blood cell, and this is where people try to differentiate what nutrient they want to give. And we're going to talk about each one of these, of course, and I think this is where people get themselves into trouble, is that they look at an MCV, they see that the MCV is high or low, and then they say, oh, you have an elevated MCV, you need B12 or folate, or you have a low MCV, you need iron. And because of that, and because it's such a common issue, I'm going to show you how there could be numerous nutrients that are involved and be really giving us an abnormal MCV or MCH or MCHC, and yet we've been trained to pick one or two nutrients that, once again, are getting us into a situation where we're not correcting the person's nutritional deficiencies, but we're masking them because we're giving so much of one versus another. So, of course, when we look at a MCV, we know that this is the average volume of the red blood cells collected in sample. So we may have some small ones, we may have some large ones, and of course we want the normal size or the middle example there. As you know, the red blood cell is large when it's in the bone marrow, and it matures and gets smaller as it goes into circulation. And this is where the macrocytic cell goes into the normocytic cell. Now, in order for it to go from a larger to smaller, this is where it involves DNA and RNA. And this is why when we think about a macrocytic cell not going into the normocytic size type of cell, that what nutrients affect DNA and RNA. B6 affects it. Of course, B12 affects it. Folic acid affects it. So those are some of the nutrients that we know have to be looked at when a person has a macrocytic type of anemia. On the other hand, we have to realize that there are some nutrients that are synergistic that, once again, can cause a cell to stay large and not continue to mature and go into the normocytic cell. An example of that would be vitamin C. Now, if you have an MCV that's normal, so it's within normal range, we then think more of antioxidants. We think about cell membrane integrity. What nutrients are actually protecting the cell and going to decrease it from hemolyzing? Well, these are some of the nutrients that are noted in the literature that protect the red blood cell from damage. And you can see some of them involve minerals, some vitamins, and once again, essential fatty acids. So if you saw a person that had a low red blood cell count, the MCV was normal, the MCH was normal, and the MCHC was normal, the question I have to you is, what would you prescribe to that patient? If you didn't have a in-depth analysis of the nutritional status like the micronutrient test, there is no way that you could pick the right nutrient. And these are some of the ones you have to choose from. So you might say, well, this person has hypothyroidism, so maybe it's selenium. Or this person has, a gallbladder that's been removed, so maybe the fat solubles are going to be malabsorbed, or maybe it's vitamin A and vitamin E. Or maybe the person's taking a PPI, which of course decreases the acid, and of course that affects the minerals, especially copper. So we might suspect a copper deficiency there. But the point is that you would be guessing rather than really knowing what nutrient or nutrients are required if they have an abnormal red blood cell count but normal size cell. Macrocytosis, once again, you can see, of course, the B12, the folic acid, the B6, and the vitamin C. And once again, the vitamin C is very synergistic with folic acid. So if we have an elevated MCV, these are the 4 nutrients that you want to highly consider. But don't shotgun them, because if you gave a large amount of vitamin B12, it may actually mask a folic acid deficiency or a B6 deficiency, something like that. So that's why you want to have a particular test like the micronutrient test to specifically tell you what nutrient or nutrients you need to provide. And these people can have these deficiencies and yet not present with an abnormal CBC. And that's why, as I mentioned earlier, people come into our offices, say they're fatigued, say they're stressed out, they have all these issues. We do the typical CBC, CMP, as well as your analysis. They all come back normal and say, oh, goodbye, you're healthy, there's nothing wrong with you, maybe just decrease your stress a little bit, rather than saying, okay, these tests, the CBC and CMP, are not real specific, so even though they're beneficial for certain things, we need to do something more specific like a micronutrient test to see if you're on a borderline level that's not really displaying abnormal in the CBC yet. Microcytic, once again, for all of you that have treated a low MCV with just iron and only considered iron, you can see that you're missing some other nutrients here. We always give zinc with copper. As you know, we try to keep zinc to copper in about a 10-to-1 ratio. Iron, once again, is affected by copper. Iron is affected by B2 as well. Iron is affected by acid environments. So once again, if a person's taking a PPI, they could have a high tendency to have an iron deficiency, just like a copper zinc deficiency as well, or even protein deficiency. So as hopefully you can see at this point of the talk that there's several nutrients we have to consider when we are looking at a CBC, and we have to have further diagnostics to really pinpoint what we want to provide to these patients. What about the MCH? Now, as you know, the MCH is the mean corpuscular hemoglobin that is looking at the weight, the average weight per cell of hemoglobin. And once again, any nutrient that has an impact to make hemoglobin actually can decrease our MCH. And so you can see there's a crossover here between the MCV and the MCH, and this is why we often see a person that has a microcytic anemia often has a hypochromic anemia, and that's really determined more by the MCHC than it is the MCH. But this is one of the indices, of course, that we look at and is correlated with these nutrients. An increased MCH, of course, the cell is a macrocytic. It's going to have more hemoglobin typically if the person has adequate amounts of the nutrients that make hemoglobin. That would be your zinc and your iron and your B6 and your protein. But you can see, once again, there's some crossover there. So a person has a low B6, which is very important for the first step of heme. They have a low B6 that affects RNA and DNA and the division of the cells or maturation of the cells. And that's where you'd have possibly a macrocytic type anemia with a hypochromic presentation in regards to color of the cell if you're looking at it from a microscopic view. So once again, thinking back over your career and saying when you look at a CBC and you've seen people with an elevated MCH or an elevated MCV, what did you give them or what did you suggest? And did you limit yourself or did you do something like a serum B12 or a serum folate that is not very accurate and came back normal, and yet maybe the CBC was abnormal? And so you didn't really know what to give and you just kind of shotgun it. And once again, it is important that we specifically address it. Now, generally speaking, the MCH, when it's increased, we often associate it with a macrocytic anemia or an elevated MCV. This isn't always true, but more times than not that it usually correlates like that. So it's something that we want to keep in mind. On the other hand, when the MCH is decreased, we often associate that with a microcytic anemia. So this would be a microcytic hypochromic type anemia. And of course, most people would jump on iron because it's a metallo product and has a huge impact with the color and presentation of the cells. But as I mentioned, if you don't have the other nutrients like B6 and zinc along with the protein, you're not going to make hemoglobin, and you're going to have a decreased hemoglobin, a decreased MCV, and also a hypochromic presentation when you look at it with a microscope. The MCHC, now this is a concentration, of course, or percentage of hemoglobin per cell. Once again, so anytime we're looking at the concentration, we're looking at all of the hemoglobins. When we look at the MCH, we look at the weight of the hemoglobin, the average weight of the hemoglobin. And this is when we get into what we call the minor hemoglobins. And of course, one of the minor hemoglobins that we often talk about is hemoglobin A1C. So when we think about hemoglobin on a CBC, we're gathering all the hemoglobins, and that's our hemoglobin number. And once again, several things can affect that, but you can see these nutrients definitely will make the concentration of the MCH go down. Now, switching over to white blood cells, of course, if you saw a person that had a low white blood cell count, what happens a lot of times is people say, oh, you must have a viral infection, because viral infections typically make the white blood cell count go down. Bacterial infections typically make the white blood cell count go up. But you can see that a person could have a low white blood cell count, general white blood cell count, and these could be some of the deficiencies. So when a person comes into you and says, oh yeah, I've got GERD, I've been taking Nexium or one of the other PPIs for years and I'm fatigued, and the first thing you'll say, well, let's give you a B12 shot. Well, that may sound fine at the time, and a person may get some benefit from that because B12 deficiency does occur with PPIs. But you can see that there's other nutrients that also come into play as a result of a PPI usage, and that would be your copper, your iron, your zinc. And so as a result, that's something that we have to consider, but you wouldn't be able to determine that just by a CBC. In fact, I saw a patient today, one of his major complaints is he's fatigued. Well, he's type 2 diabetic, and of course he's on a medication called metformin. And what was beautiful about his case today is he actually had a B12 deficiency, not a borderline, but a functional deficiency. Now, the literature talks about B12 and folate being affected by metformin, but this particular test, the micronutrient test, further confirmed that this person actually had an intracellular abnormal B12 status. And we know that when B12 is low, people are fatigued, and that was his major complaint. So he was thinking his blood sugar, his blood glucose levels were out of whack, but in essence, it was actually some of his nutrient deficiencies that were causing this. So you can see, once again, next time a person gets sick and they don't have the immune status or power to fight an infection, that it may be a nutritional deficiency like one of these. Neutropenia. When we see a person's total white blood cell count go down, and then you see the neutrophils specifically go down, one of the first nutrients you want to look at is copper. Copper deficiency is highly associated with neutropenia and leukopenia or leukocytosis. Actually, not leukocytosis, leukopenia. So if a person has leukocytosis, we often think of a bacterial infection and what might be doing that. But once again, if we see a decrease in white blood cell count along with specifically neutropenia, then you want to think of copper. Now, iron will, once again, or can cause a abnormal white blood cell count and occasionally a neutropenia status, but copper is more common to do that. And once again, copper and iron are both affected highly when we take a medication that decreases our hydrochloric acid in the gastric region. When we have a decrease in lymphocytes, you can see that there's certain nutrients that we look at. We look at glutamine, we look at vitamin A. So this is where we would see that on a micronutrient test. So a person comes into your office, they're sick all the time, and they start to have some changes on their CBC. The point is, what do you do with it? Do you say, oh, it's a bacterial or viral infection? Or you say you may have a nutritional deficiency that's present that will not allow your immune system to work at its highest capacity. And as a result, until you correct that, you're going to continue to have this person that has illnesses. And I see this all the time where parents bring their kids to me. They're sick every 3 to 4 weeks. They go and get antibiotics, and they get sick again 4 weeks later, and they keep going for 2 or 3 years like that. And then these parents finally get tired of that, and they say, well, there must be some underlying problem. They bring them, we do this micronutrient test, we see these particular deficiencies that correlate with the various white blood cells and or red blood cell, and we correct that, and now these people are winning attendance awards in their school. They're not sick for an entire year, and yet they were sick every 3 or 4 weeks for years. So, it's not a placebo effect. You don't have a placebo effect like going from sick that often to, winning attendance awards, especially when you've done something nutritional to them and you've seen the nutrients improve on the micronutrient status. Now we're going to get into a comprehensive metabolic panel profile, which all of you are familiar with. And because of my time today, I can't cover every one of these markers and how it correlates with the nutritional status of an individual. But the point that I want to make is that some of the nutrients that I'm going to show you that are borderline or functionally deficient are affecting the CBC and comprehensive metabolic panel, but not to the degree that they're abnormal. So if you look at the top of this particular page, you'll see that this patient's glucose is 96. And normal, of course, is 70 to 99. So is she within normal range? Yes. The question is, though, do they have a situation where they might have a functional deficiency or a borderline deficiency on a micronutrient test that isn't yet displaying an abnormal glucose, but is getting close to an abnormal level. So this is why serial testing is so important, where patients say, I used to run a 78 glucose all the time, and now in the last 3 or 4 years, it went from 78 to 82 to 85 to 94, now 96. That's a trend. There's a reason why that's happening. And this is where the micronutrient comes into play, and we have to say, okay, let's see what nutrients affect your glucose/insulin receptors, and once again, can address that before this person gets into an abnormal CMP with their glucose. Now, as you know, on a CMP, one of the tests that we look at is the ALT, and this particular aminotransferase, I think everybody usually talks about this as a liver enzymes. This is one of the 2 liver enzymes. We look at ALT and we look at AST. And most of the time we look at it from an increased standpoint. And so the person says, well, yeah, if you have increased ALT, you have liver disease. Well, they may have liver disease, or they may be taking something that's actually affecting their liver, and it could be something like vitamin A in large dosages or niacin/nicotinic acid in large dosages. And this is why if you're treating someone that has hypercholesterolemia or hypertriglyceridemia, that you give these individuals niacin, and you want to monitor their CMPs on a regular basis and make sure that their ALTs are not going up. Now, as I mentioned, most of the time people associate ALT with the liver, but you can see here that ALT is found in the heart, is found in skeletal muscle along with the liver. And so even though a lot of us have been trained or told in our training that this is a liver enzyme, it's not the only tissue that's involved or could be involved. And this is why we have to be careful on just saying, oh, you have liver disease with an elevated ALT, when in actuality you could have some of these other organs involved. The AST, of course, is the partner to the ALT. And once again, as you know, we used to go through SGOT and SGPT, and now most labs use ALT and AST. And this is another example how you could see an elevated AST, and it could be something like these. On the other hand, what happens if you see a decrease? What happens if a person has, say the normal value for an AST or ALT is 0 to 42, and you have a patient that has 4. You say, oh, that's great. You don't have liver problems because you have a low AST or low ALT. Is it really that that's good? Or is it that that person may actually have a B6 deficiency because B6 helps make this particular enzyme? So a low level of a so-called liver enzyme that we are so commonly associated with may actually indirectly tell us a deficiency. But this is once again telling us on serial testing. And who would once again be more prone to this? As I mentioned, women on oral contraceptives, people that are following a gluten-free diet. Those are individuals that would be more prone to this. People that have an abnormal MTHFR, that could also come into play. Albumin. Now, this is an interesting thing, of course, for all of us that have been in this field for a while. We know that albumin is the protein that we look at for protein malnutrition in individual. And as you can see here, albumin actually has a half-life of 18 days. So if you are looking at a person that has a low albumin and you start giving them a lot of protein to help their albumin status, it's going to take around 18 to 20 days before you see a change. So if you did that, if you calculated out a certain amount of protein, thought this is the amount of protein they need to correct their protein deficiency, and you check them in a week, you're not really going to be able to see much of a change or significant change. There's another test I'm not talking about today because it's not on a CMP, but it is on a test that you could, from a lab that you could perform that, once again, is a little bit more specific. It's called prealbumin. And prealbumin has a much shorter half-life, and so you can tell within 4 to 5 days on whether or not the protein that you're given is adequate, rather than waiting 18 to 20 days and say, oh yeah, the amount of protein I was giving you wasn't enough, so now we need to increase it. Well, wouldn't it be better to see that in 3 to 5 days or 7 days than it would be in 18 to 20 days? So even though albumin is used a lot for protein calorie malnutrition status, you can see that things can occur. But look at this. There are some other nutrients that are involved. Vitamin C deficiency can decrease our albumin. Our iron deficiency, of course, renal disease like nephrotic syndrome, and of course your generalized protein status, and of course a person could have liver disease, and one of the situations would be, of course, hemochromatosis. And elevated albumin, once again, going back to, did this person come into your office dehydrated? And, you know, just because they walk in and maybe they even haven't been, you know, exercising anything, they could be on a diuretic and they could maybe not be consuming a lot of fluid on a regular basis, and so they're showing with an abnormal albumin. Alkaline phosphatase. Once again, a lot of times people, when they look at alkaline phosphatase, they think of one tissue. They either think of bone tissue, skeletal tissue, or they might think of the liver. But as you can see, that there's, in addition to liver, the GI tract also has a responsibility with alkaline phosphatase. I didn't put it on here, but the placenta also has a role with alkaline phosphatase. And like I said, we usually think about alkaline phosphatase being elevated as being a problem. But here's a situation. You can see there's numerous nutrients that could actually cause a decrease in alkaline phosphatase. So you could have a normal alkaline phosphatase. What I mean is a low normal alkaline phosphatase, thinking, oh, that's good because the person doesn't have any liver problems or doesn't have any skeletal problems, but it could indicate that the person might have something like pernicious anemia or folic acid deficiency or zinc deficiency or something like that. So I think we really have to change our way of thinking, the way you were trained, because most people look at these enzymes as we want to make sure they're not elevated. But on the other hand, you can see from a nutritional standpoint, if there are certain nutrient deficiencies, we're going to have a decrease of these enzymes. Here's an increase here where vitamin D deficiency / rickets. We have a vitamin A toxicity, which could cause that, of course, calcium malabsorption, manganese deficiency, and, of course, primary hypophosphatemia could also do that. So, once again, there's other conditions that can cause an increase in alkaline phosphatase and other pathologies, but I tried to relate it all to nutritional status at this point. As far as there's different breakdowns. There's an alkaline phosphatase in the white blood cell, and you can see this is, once again, if it's decreased in the white blood cell, it could be a B6 deficiency, and that could be telling us something about the person's generalized B status. And once again, if they had an abnormal MTHFR, we may see an abnormal alkaline phosphatase. Glucose, I talked about this earlier where that individual was at a 96, so they weren't above the normal range, but they were creeping up. And I hear this all the time from clinicians. They'll say, oh yeah, my patient doesn't have diabetes yet, but you know, I've been watching their blood levels for the last 6, 7, 8 years, and their glucose keeps climbing, their HbA1c keeps climbing. And you say, well, what do you give them? Well, once again, these are some nutrients that are associated. And I want to kind of skip down a little bit down to about the 7th, I think it's 1, 2, 3, 4, 5, 6, 7. Yeah, the 7th and 8th bullet where you see a niacinamide deficiency could cause an elevation in glucose, where a elevation or too much niacin or nicotinic acid could actually cause an elevation in glucose. So depending on what form of niacin you use would determine whether or not it actually would be the causative factor. Decreased glucose, of course, we can see that in chromium deficiency. We see that when people have hypoglycemic, reactive hypoglycemia, where they may have that. Cholesterol, once again, so, we talked about a cardiometabolic panel earlier this month and correlated it with various nutrients on the micronutrient test, and once again showing that how it can affect us on a comprehensive metabolic panel. As a person comes in, they have an elevated cholesterol, and you might say, well, take fish oils or exercise more or get on a low cholesterol diet. Well, those things may help, but how many times have you seen a person exercise pretty rigorously, maybe 4 or 5 times a week? They eat pretty healthy, meaning according to most people it would be a very clean diet, and their cholesterol is elevated. And you say, well, it's hereditary. It must be a hereditary factor. Is it really a hereditary factor, or is it that you didn't discover the right nutrient deficiency? Because if you look at this particular slide, you'll see that there's several nutrient deficiencies and one toxicity that can cause a cholesterol elevation. And so how did you rule those out? How did you determine what to give that patient? You gave them fish oils, but yet you can see none of these on the slide. Talk about omega-3s. We're talking about copper, magnesium, chromium, of course, vitamin C, pantothenic acid deficiencies. What about a decrease in cholesterol? Everybody talks about not having too high cholesterol. What happens if you have a decrease? Once again, you can see there's certain deficiencies that are associated with this as well. You can have maybe too much niacin where you're actually dropping it. Now, depending upon who you read, there is information out there that when we get our total cholesterol under 130, that it may actually push someone into depression, anxiety, or even suicidal tendencies. They did some research with some inmates, and they actually discovered this. So I think we're going to discover this as a general population is if we keep pushing the cholesterol levels down as far as total cholesterol to cut out so-called heart disease, are we really doing the right thing? Because there's a lot of nutrient deficiencies that may be causing this, and until you correct those, you're going to have an abnormal cholesterol from a decreased level versus, of course, an increased level. Triglyceride elevations. Once again, when we talked about lipids, one of the first things people say is cut out the sugar, cut out of course, your fat, and your triglycerides will go down. The person says, I don't eat any sugar. I am a low-fat diet. I exercise all the time, and how can I have an elevated triglycerides? Oh, it must be hereditary. Once again, is it really hereditary, or is it a particular deficiency that is causing this to occur? And this is why the micronutrient test is so valuable. I try to connect the two, is because a person has a cardiometabolic that shows an elevated triglyceride, or they have a comprehensive metabolic panel like this that all of us clinicians have been trained on, and we're trying to decide what to put them on to help lower that. And once again, omega-3s do a good job, but are you just correcting it by giving omega-3s, or are you also correcting the problem? Because if you have an underlying magnesium deficiency per se, yes, you may lower the triglycerides, but you're still not getting to the root of the problem. A decreased triglyceride, once again, niacin in large dosages can do that. Of course, inositol hexaniacinate is often called the non-flush niacin. This one does not work consistently. I've tried it several times. I have other clinicians that have done the same thing. I know some of the literature says it has some effect, but based on a lot of people that I've tried it on, it has very minimal effects. You can see malabsorption. Maybe the person has a situation where they're malabsorbent, maybe they have celiac disease or Crohn's disease or ulcerative colitis or something like that. So a low cholesterol in those cases is not a good thing, because you know if triglycerides are low because of malabsorption, it's not just malabsorption of fat like triglycerides, it's probably malabsorption of other nutrients as well, and that's what gets us into trouble. So I think you can see, and like I said, I wasn't able to cover everything on a comprehensive metabolic panel, but I think with the CBC and the comprehensive metabolic panel, you get the idea that when you see abnormalities on those general tests and common tests that are available, that it may not tell you the full picture. And by just being a general marker, it's giving us some indication that we have to correct something, but we don't really know what nutrient until we, once again, correlate a micronutrient test with it. So this is some information here to contact SpectraCell if you have further questions or comments on this. And so once again, I thank you for your time and attention. These webinars are archived, so you can refer back to these at any time. And this month, once again, was dealing with these various tests and diabetes. And next month, we will be talking about thyroid with these particular testing. And I'm going to correlate what the literature says in accordance with the micronutrient tests and common tests like the CBC and CMP, along with the cardiometabolic tests. So once again, I hope that this was somewhat beneficial to you and giving you a different idea on what to look for and all the nutrients that you have to consider when you are evaluating a person on the typical general screening test of the CBC CMP. Thank you for your time and have a good day.